afternoon. Today we have the pleasure to hear Dr. Claudia dos Santos tell us about an extremely important topic, which is also her area of research. So as a surgeon, one of the most disappointing things that we have is you save a patient's life. A patient comes in with hemorrhagic shock or with intra-abdominal sepsis. You do everything pristine. The operation was perfect. You control the hemorrhage. The patient is alive at the end of the operation. And obviously, we have to send this patient to the intensive care unit for further recovery. And all you know is that on the next day, when you go see the patient, the lung is completely white. The patient is in extremely bad shape. The blood pressure is low. The oxygenation is not enough to provide adequate oxygen to the tissue. And even though you did everything right, you operated on the area that was injured, the patient ends up dying of multiple organ failure. And your stitches are still there. You're in the same place, completely without any problems at all. So this scenario that I just talked about is the area where Dr. dos Santos has most of her research interest. This is called a systemic, exacerbated systemic inflammatory response, and the area that is most vulnerable to this aggressive systemic inflammatory response is the lung. 65% of our neutrophils, if we stop our circulation right now, are in our lungs. So all this inflammation that I talked about is caused by excessive neutrophil stimulation for the most part. And Dr. dos Santos' research is what she is trying to do is how to modulate this inflammatory response so that we can have some inflammation which is necessary for recovery, but not an overwhelming inflammation that causes this aggressive auto-destruction of our lungs. So I'll be very happy to hear her talk, and I hope you guys enjoy it. Welcome, Claudia. By the way, she's from Brazil, so we speak Portuguese.
Thanks, João. I can't believe you're gonna blame me for a patient's death in the ICU. Spoken like a true surgeon. All right, so you guys, it is such a pleasure. I've never really spoken to students that were not like either postdoctoral students or very advanced older kind of guys. So I am very informal. I really don't mind if you interrupt me to ask questions. I won't take it personally. And the other thing is, I showed this talk to my 16-year-old son last night, and he told me, "Mom, you can't show these gruesome pictures." So I did tone it down a little bit. Some of the gruesome pictures are gone. But if you are squeamish, raise your hand, and I will try and anticipate when the disgusting slides are coming. I don't have too many. And so you don't lose your lunch somewhere and make somebody very, very upset, okay? So with no further ado, let me talk to you guys about a little bit about what I do and critical illness. But before I do that, because I haven't really done this before and I have no idea where you guys are from, maybe you'd like to tell me, like, what do you guys do? Where do you guys come from? You guys? You go to high school here? Is it a high school? UCC? Fantastic. This is the all UCC row? What about you guys in the back there? Are you UCC too? Crescent. All right. What about you guys? Some of you guys I actually know. Some of you guys there? Where do you guys go to school? Volunteer? Fantastic. What about you? Oh, all right. Fantastic. You're medical students already? All right, great. What about you guys here? You guys look like you have a tie from a uniform. Is that right? Branksome Hall. I don't recognize, I didn't go to high school here, so I don't recognize some of the uniforms and So forgive me. All right, so medical students, and we have some high school students. All right, and you guys?
We're next door, St. Michael's Choir.
All right, fantastic. All right, so, whatever. I tried to sort of, I tried to do the lecture so that it would be understood by some people who have had a lot of biological training and some people who haven't done a lot of biology, okay? But feel free to interrupt me. I'm not as evil as I look. All right, so this is what João said. I actually came from Brazil. And Brazil is a huge country, very much like Canada. It's one of the 5th biggest countries in the world. And I was born all the way in the south, in the border with Uruguay, which you must know if you play soccer, right? Uruguay is not unknown. And Brazil has a huge soccer team. My husband is from Uruguay. We have huge fights at home. And this air company is actually the flight that is gone out of business now. But it was a very exciting talk right now. And when I was young, my dad traveled a lot. I spent a lot of time alone. And one of the biggest influences in my life was a little toy that he bought me. And I suspect some of you have received some of this stuff as well, right? Some of these science kits or microscope. Maybe some of your parents really tried to stimulate you to think about science as a future career. Well, I spent a huge amount of time on my own fidgeting with these little gadgets. I love to take insects, plants, whatever. And I was a bit of a nerd. And I will confess to you all, although I hope you don't hold it against me, how bad of a nerd I was. I love Star Trek. I don't dress the outfits. I don't go to the Star Trek conferences, okay? But I'm just borderline Star Trek fanatic, all right? I used to watch a lot of Star Trek in university, and one of the things that I most enjoyed about Star Trek was, of course, the sick bay, because I love the fact that this woman, and Beverly Crusher is not my role model, okay? She's just too mild for my, you guys know, if you guys have watched the Next Generation Star Trek, you know that she's a bit, I'm a little bit more heated. I got a little bit more passion in me. But I loved the fact that she had all these advanced gadgets and she worked in this fabulous sick bay and they had all this technology around them that enabled them. And it was just amazing that they would go and identify what was wrong with you. I wish we had some of those diagnostic devices with us right now. So this really influenced me in my choice of sort of going into science before I went into medicine. So I did all my graduate work before going into medicine. And after I finished my graduate work, I thought, this is fantastic. I love what I do. I love science. However, I want to make it applicable to humans. I want to actually be able to help people. And that's sort of the way that I got into medicine. I initially thought, I thought I was going to do pediatrics, and I thought I was going to do dermatology. And it was a real surprise to me when I got into medical school. I didn't plan it that way, mind you, that I loved sick people. And the sicker, the better. The sicker they were, the more engaged, the more desire I felt to be in the hospital for hours on end. I loved my calls. After a whole night of being on call, I'd get up in the morning, cold shower, espresso, and I'd be ready. I really, really loved what I was doing. And some of the patients that I take care of look a little bit like this. So this is a very complex environment. Patients are usually extremely sick. So you see here the patient sort of in the middle of the room. And this guy actually has what Dr. Resende was saying. He had acute respiratory distress syndrome. So there are actually 2 ventilators beside him. The mechanical ventilators are machines that help you breathe. They're actually life support machines. And you can see that the patient is actually hooked up to the machine. This is sort of like conventional ventilator. This is what we call a high frequency oscillator. And we don't use it very much anymore because the science has gone against it. But we used to use it a lot while I was training. And patients have tons of IVs, tons of monitors. And when you're committed to taking care of a patient like this, honestly, time goes by like this because you're so engaged in every single aspect of this patient's care. And as a critical care intensivist, unlike other subspecialties, we don't focus on a specific area. The entire patient is our problem. all the organs become part of what we do for this patient, right? We take care of all the organs this patients have. Now, who really needs mechanical ventilators? Now, I'm sure that you guys have seen some of these talks. You've seen some of the talks about acute resuscitation. And you know that when organs fail, when you've got, for example, a massive heart attack, when you sort of do the defibrillation, you give the cardiac compressions, one of the things that you do for the patients is you actually intubate them. You put a tube down their trachea and connect them to a mechanical ventilator that breathes on their behalf. And as João pointed out, what do you do with them afterwards? Where do they go? So you've reestablished a circulating rhythm. You've reestablished a breathing pattern. Where do they go afterwards? They come to me. They come to the intensive care unit where we provide them with life support. Now, tons of different patients require life support. There are a variety of different reasons why patients need to come to the intensive care unit. They may have had an overwhelming infection. They may have had massive trauma requiring intubation. They may have, for example, some sort of obstruction to their bowel that leads to poor perfusion to their gut, so that their bowels now become blue with no oxygen, and that causes significant injury in the rest of their body. They might have had a massive GI bleed, so this is not only heart attacks, right? They might have acute heart failure, which some of you may have seen in the past, or they may be even acutely immunosuppressed. So we see a lot of patients, for example, post-chemotherapy or something of the sort, where they develop significant infections after their chemo, and they require ICU admission for us to be able to manage them. And the things that we do in the ICU is we replace their failing organs. So we give them the mechanical ventilator to help them breathe. We give them drugs to preserve their blood pressure. We try to maintain flow of blood to their distal organs. We give them sometimes dialysis for renal replacement therapy. There are some advanced places that actually do replacement of liver function. So what we do is we buy patients time. Precious, precious time. Intensive care is not curative. None of these machines actually cures patients, right? None of it actually solves the underlying problem. But all that we can do is buy the patient time. Buy time for antibiotics to work, buy time for the surgery to work, buy time for the body itself to heal. And by buying time, we cross our fingers, do everything that we have to, and hope patients will get better. So a lot of what we do in the ICU is manage disasters, try to keep patients contained so that we can get them some time so that they can get better. And while we do that, we replace their organ functions. Does anybody know who this woman is? Do you guys know? This lady? No? So this is Florence Nightingale. And the reason I put Florence Nightingale up there is because throughout history, until Florence Nightingale, nobody really recognized that critically ill patients, that patients that were really sick, needed to be separated and taken care of a little bit separately from other patients. So during the Crimean War, Florence Nightingale revolutionized the care of patients simply by creating a place where she would put the patients that were really ill, separate them from the ones that, had a scratch, a wound, or whatever, right? And what did she do in that place? She made sure that that place was significantly clean, that there were much less bugs around for patients to get complicated infections. And most importantly, she assigned a dedicated nurse to take care of these sick patients. One of the most important things that we do in the ICU is assign a dedicated person and monitors to watch over patients so that at any change, we can move quickly, because time is life. If we delay treatment, patients really die. delay of treatment is one of the major reasons why patients actually reach their demise. So being able to effectively monitor them and intervene in a really quick way makes a difference, especially when patients are really sick. So this is sort of the beginning of the ICU. I just wanted you to show you this picture. So ICUs really didn't exist until the 1950s. So this is a very, very young subspecialty compared to other subspecialties that you can think of, even like surgery that began in ancient Greece or even the Phoenicians. Critical care only existed since the 1950s. And it only became a conceptually realistic model to have patients on life support during the polio pandemic. Anybody knows what polio is? Sorry, I didn't hear you. It is a virus, and what does it affect? Don't you all answer all at once, because you're like, swoon. What does it affect? What system? The immune system. It actually affects your nervous system. Does that make sense to you all? So it's all good, no problem. So it actually affects your nervous system, and it interrupts, damages your nerve system so that the nerves can no longer communicate with the muscles. Which muscle is your biggest breathing muscle? Diaphragm. Good job. So if you don't have good diaphragmatic function, the diaphragm contracts, pulls the lung down, generates negative pressure like a vacuum in your chest, and forces you to take in air, right? If your nervous system is not working, you can't do that. You can't breathe. All these patients with polio would die from their inability to actually breathe. So this is actually called the iron lung, and it was a chamber, and you'd put patients inside this iron lung, and you'd generate negative intrathoracic environment, and it would actually suck the diaphragm down and force the patients to suck air into their lungs. It's called a negative pressure ventilator. And the first sort of big unit with all these ventilators around was actually in Copenhagen in 1953. That's how we think about sort of like the birth of the conceptual idea of intensive care unit. And this photo I'm showing you is from a hospital in Los Angeles, but it just gives you an idea of how big this room was, sort of where all the critically ill patients that require the same type of care, how they are bunched together so that the expertise of the people that are taking care of these patients can actually be capitalized. So as the time passed, these iron lungs became smaller, more portable. So this is a man sitting with a smaller iron lung. This is a big vacuum tube, sucks air, creates negative pressure, sucks the diaphragm down. He can take air. And don't think this poor nurse she's not cruel. She's not trying to torture this guy, showing him that he can't benefit from the vaccine. What he's showing him is that medical advances, the development of the vaccine against polio, was one of the major revolutionary things that happened at that time. And it changed the world completely, because from that moment onwards, people didn't have to be on the iron lung. In the interim, as this was happening, sort of companies were trying to develop a more portable ventilator. So this is Draeger. It's a company that makes tons of ventilators, and I just wanted to show you this photograph from 1910. And they were able to develop this machine that instead of sucking air, creating a negative pressure and sucking air into your lung, it actually blows air into your lung. This is called positive pressure ventilation. Rhythmic inflation apparatus, because obviously the inflation happens in a cyclic, right, rhythm, right? And this is really great because they're much more portable, they're easily transportable, and they made life for the critical care intensivist much easier. And nowadays, these are the ventilators that we use. They're positive pressure ventilations. They don't suck air, they actually blow air into you. Now, we were talking about research, and I just wanted to let you guys know where research is important and relevant, and what kind of research do I actually do. So you may have heard a lot of people that are doing bench-side research. They do basic science, animal studies. Lots of people who came here to present, I know, do clinical research. They do research directly with patients, trying different treatments on patients, randomized controlled trials. So I know that you've seen some of those cases. Some people do research more towards clinical practice and how the care is actually delivered. And some people that you know, especially here at the Sea Ridge, right, do populational health. So my research is all the way at the basic side of life. So I do a lot of research at the level of the cell and at the level of the genes. And my sort of ultimate goal is actually translate that bedside research to clinical practice. So what do I want to do? Identify potentially novel treatments for the treatment of important critical illnesses. One of the critical illnesses that I really work with is called sepsis. And I don't know how much you guys know of sepsis, but sepsis is a disease that happens when bacteria from anywhere, okay, gain access to your circulation. They're no longer localized. They get into the bloodstream. Once they are in the bloodstream, the bacteria go everywhere. They go to your brain, to your heart, to your lung, to your kidneys, to your liver, to your foot, to your toe, to your stomach, to your insides. They have access to everywhere. And bacteria make toxins. Not only do bacteria multiply and duplicate and enjoy the nice nutrition that is inside your circulation, they also exude all these lovely toxins. And as the bacterial infection gets progressively worse in your bloodstream, you go from having what Dr. João said just earlier, which is a systemic inflammatory reaction, which is your body's reaction to the bacteria, the fever, the chills, the riders, right? To actually, I just knocked it out, didn't I? To actually having end organ damage. It affects your spleen, your liver, affects your kidneys primarily, and eventually causes significant low blood pressure, requiring you to go to the ICU and get on medications that would allow your blood pressure to be maintained so that you don't die. And we need to buy time for the antibiotics to work. So that's what we're doing with these guys. So let me just show you an example. This is a guy with a tooth abscess, okay? And a tooth abscess is innocuous enough, right? Until bacteria actually gain access to his circulation and start circulating in his bloodstream. Blood is then carried to all the major organs, making people really sick. Blood clots throughout the body become activated because the cells that line the vessels in all your body get activated. They become activated by the bacteria, and so they also generate clotting factors, making small thrombi, making all kinds of abnormalities in your coagulation system. And as it progresses, you develop a complete global response to the infection. That is called the systemic inflammatory response syndrome. If unchecked, if you don't stop this, right, patients develop septic shock, which is the low blood pressure. Then they develop organ failure. And as I've told you, their lungs fail, the heart fails, the liver fails, the kidney fails. And once those things start happening, once you start failing organs, it can't be replaced. There's no bank of organs you can go and just put tons of organs back. The patient is infected. There is no way that you sometimes can reverse the sort of, it's like an avalanche. It's like a huge snowball that takes control, and you can't stop it, ultimately resulting in death. As João said, the lung is one of the major organs that is affected by this. Why the lung? Why the lung? Because it has these sinusoidal spaces. It works very much like a filter. You know that a lung looks like a sponge, right? So it entraps. The bacteria get entrapped in the lung, and the inflammatory cells also get entrapped in the lung, making the lung a major target for injury. Why do I care? Because then I need to intubate those patients and ventilate them. So if Ice Cube is gonna say it, It's going to be good. So this is an example of how sepsis happens. I hope you all enjoy this video, and I hope it brings it home to you all. It happens very fast, so pay attention.
Shot man.
Don't say that.
You know anything about gunshot wounds?
I don't know.
Specifically, the worst thing about a gunshot wound, provided that you survive the bullet, is something called sepsis.
Infection of the blood.
That's right. Say a bullet tears through your gut. Creates a cavity of dead tissue. That cavity, it fills up with bile, bacteria. You're fucked.
That's it.
We're gonna do this about 5.
If George Clooney says it, it must be true, you guys. Now, I just want to take one step and talk a little bit about the lung, okay? I told you about the sinusoidal structure of the lung. So usually the lung, so look here on your, I don't know, is that the left side? No, that's the right side for you all. On the right side, the lung is not supposed to have anything inside the alveolar spaces. That makes sense, right? Because it's supposed to have air. What happens during sepsis is bacteria, or even in ARDS, all kinds of injurious things that you can have, even from non-bacterial infections, they can get access to the lung. When they gain access to the lung, what happens is between the alveolar sac and the capillary, there is one membrane. It's called the interstitium. This is the alveolar capillary membrane. And any damage to that membrane causes injury to either the alveolar cells that are sitting on the air side of the membrane, or the endothelial cells sitting on the capillary side of the membrane. And what happens is stuff, and what's stuff? Stuff is protein cells, bacteria, enzymes that are in the circulation and are supposed to stay in the circulation. They enter the airspace. Now, if your airspace is filled with gunk, it's a no-brainer. You can't put air in something that is already filled, okay? So as you can't breathe, you require the mechanical ventilator. When you look at the chest x-rays of these guys that have ARDS, you look here all over the side, you see this cloudiness. That's what we call exudative fluid. It's fluid that has inflammatory things in it. Bacteria, enzyme cells, all kinds of different things. When you look at the CT scan of the chest, so this is a CT scan of somebody with ARDS, you see that there's this cloudiness, this haziness. Again, it's fluid filling the alveolar spaces, and it's diffuse. It goes everywhere. This is a PET scan, and it shows the amount of lung water, and these lungs get filled. The alveolar spaces actually get filled with fluid, and that's why these guys can't breathe. It's not only sepsis that causes this, and some of you may be too young to actually remember this. We were on when the SARS pandemics, and we've been on now for the H1 pandemic. But there's a lot of other causes for ARDS. One of the most common one is viruses. And you were around, you know, the SARS thing, the HN1 thing, and various respiratory pandemics are also a significant risk factor for acute respiratory distress syndrome. Now, most of these diseases, okay, are potentially preventable. And it's really interesting is that if you look at the number of people with sepsis, so this is, I'm not showing you Canadian data because American and European data are much better studied. We do have a lot of Canadian data, but I'm not showing it today. But if you look at the number of patients with sepsis, it outnumbers the number of patients with prostate, breast, and lung cancer. Outnumbers patients with stroke, outnumbers heart disease, and way outnumbers HIV. And interestingly enough, I don't see anybody running for sepsis. I think it's part of the problem is we don't do a good job of informing people about the importance of these diseases. And it's reflected on the amount of money that we get for research. So if you look here at the millions of dollars that are spent on research, this is how much is spent on sepsis compared to something like HIV or something like cancer. Not to say that we shouldn't give money to those diseases, but to keep in mind that sepsis is very important and extremely underrepresented problem. This is how much money Canada spends on research, not in the area of sepsis, but in research in general. And you can see this is a percentage of the gross Domestic product, thank you very much. And you can see Canada sitting right there, no comments. You can see between the year 2012 and 2013 how much money Canada has decided to spend on research, sepsis included. And you can see here how much of our gross domestic product we've dedicated to research since 2008. There it goes, coming right down. It affects a lot of our ability to actually identify novel treatments, right?
Mein Name ist Mark. Ich habe 2012 meinen besten Freund Martin im Alter von 41 Jahren durch eine Sepsis verloren.
Ni Luba. Na damu da rashin 'yata Zainab, 'yar kwana 5 dalilin cutar mugunyar jini watanni 7 da suka huce.
Меня зовут Игорь. Моя сестра Анна умерла от сепсиса, который явился результатом пневмонии. Ей было 58 lет.
Meu nome é Maria. Em 2012, perdi meu marido, Leolário, de sepsis.
सुमन के पापा सेप्सिस के कारण चल बसे जब
मैं पापा को बहुत मिस करती हूँ.
My name is Patrick. I contracted sepsis aged 9 months old, and as a result, I lost all of the fingers on my left hand, the second and third digits on my right hand, and my right leg below the knee. But I survived. Stop sepsis, save lives.
But the point I was trying to get across to you guys is that it affects all people of all gender, of all ethnic groups, of all ages, in all countries. It's a huge problem. It's a huge social, individual, and socioeconomic problem. And a lot of these deaths are preventable. Okay. So now let's change just a little bit gears. What do? I do what's called translational research, which I told you about. I start from sort of the cell, sort of the basic science. I work on animal models, and I then try to develop treatments for humans. And sometimes we start with the human and go all the way backwards. What I'm going to show you is just 2 projects that we're working on. One is trying to identify novel molecular treatments for ARDS, for acute respiratory distress syndrome, which I showed you about, that lung problem. And the other one is using stem cells for the treatment of sepsis. And hopefully, I still have one more video to go, so I don't know, I'm sort of scared. But we'll see how it goes, okay? So let me tell you that I told you that now the mechanical ventilator actually blows air into people's lungs. And I told you that when the lungs are actually filled with pus, it's filled with something, so you can't get air inside it. Air is stupid. It follows the path of least resistance. So if it can't go inside the air sacules that are filled with pus, it's going to go preferentially towards the normal, the healthy lung. What happens to that healthy lung? It distends, it over-distends. It becomes hugely damaged because so much air actually goes into it. So this is an experiment where they used animal lungs. These are non-ventilated lungs, and that's the way that they're supposed to look. And if you actually ventilate it for 5 minutes with lots of air and lots of pressure, like you blow really hard on these lungs, this is what the lungs look after 5 minutes, and this is how the lungs look after 20 minutes. So this suggests that the ventilator itself can cause injury.
We're recording again. This is a different angle.
So this is a lung, okay, from an animal model. You see these areas here? They're injured, they're filled with pus. So you can't get air inside it. And I want you to pay attention to this bottom part of the lung. Do you see how it's getting overinflated? It's getting much bigger than the other one. This is a video given to me by Dr. Slutsky, who's our VP of research, and he's done a lot of research in this area. And look at how that normal area of the lung becomes a little bit wider. It's really quite distended. This is not good for the lung. So the ventilator itself can cause lung injury. And this is just a scanning electron microscope of the lung surface. And I don't know if you guys can see this. Can you see this tear through the lung tissue? That's because too much air. The lung popped. It broke open, right? That's really bad. Sometimes you don't even need that much injury to cause damage to the lung. Even the deformation of the ventilator can cause a lot of injury. And this is really important because we know from a study that was published in the New England Journal of Medicine that if you compare patients that were ventilated with low volumes with patients that were ventilated with high volumes, the patients that got the high volumes died. How much did they die? About 10% increase in mortality. So that means that there we are, working in the ICU, really trying so hard to save patients and prevent them from getting organ injury and preventing them from passing away. And the ventilator itself is working against us. This is the area where I do a lot of research. And what kind of research do? I take cells from the lung, human cells, I stretch them. I grow them on a membrane that is actually elastic. I apply force to that elastic membrane so that the cells are actually stretched. And I do the same with the animal models, okay? So we have a little animal ICU. We take care of the animals exactly the way we would take care of a human. We give them pain medication, we intubate them, we give them IV fluids, we give them antibiotics, we give them blood pressure medication so their blood pressure doesn't fall, and we apply different pressures on the ventilator to try and understand what happens when you actually stretch cells. And one of the things that I do is I try to identify what common genetic elements, what common cell changes happen when you stretch either cells or animals, okay? You stretch their lungs. And how do I do that? I use a gene chip. Are you guys familiar with a gene chip? Do you know what a gene chip is? No, I thought so. I asked my son and he said, I don't know what a gene chip is either. So instead of looking at a single gene, right, you can now look at thousands of genes at the same time. So in a gene chip, you actually spot every single gene that you can have your hands on. And there are big libraries internationally where the sequence of these genes are actually available. And what we're looking at is actually the RNA from these genes. And I don't know if you guys remember differences between RNA and DNA. But having said that, we can look at the response of not a single gene, but thousands of genes simultaneously. So that allows us to draw conclusions from patterns in whole groups of genes that, for example, are in the same chromosome or are involved in the same process. Like, for example, we can look at all the genes involved with glycolysis or all the genes involved with oxygen damage, for example, right? And that allows us to get a much better picture of reality than if we were looking at a single gene. So using this approach, I don't know if you guys are familiar with the terms omics, omic technology. So you can actually survey the entire genome of a cell, all the DNA of a cell. You can survey all the messenger RNA of the cell. If you guys remember from biology, DNA is transcribed into messenger RNA. If you use transcriptomics, you can assay all the thousands of genes in the transcriptome. And if you look at the proteins, you can actually do proteomics, where you actually scan for all the proteins in a cell at a given time. And you can use metabolomics, which now are looking at metabolites. And this is really a powerful technology because it pulls us away from single molecules and shows us the entire response of the cell. So using this approach, we've identified all kinds of factors that regulate the response to cyclic stretch, the response to this mechanical ventilator, especially if it's not a good response. One of the genes that we identified, for example, is this activating transcription factor 3, and it works because it is a master regulator of various genes that are responding to cyclic stretch. And then how are we going to use this in clinical practice? How are we going to do this to actually help patients? We're going to put this gene that is really good for you inside an adenovirus vector. Adenovirus, as you know, can cause lung infections, but these genes are actually mutated in this adenovirus, which makes it not pathological, but actually a good vehicle to transport genes back into the lung. We give this to the patient. It doesn't cause disease. It just serves as a vehicle to deliver novel genes into the patients. The adenovirus is great because it preferentially infects epithelial cells in the lung, and that allows us to give epithelial cells good genes that will help it fight against. What is epithelium? I saw you there mouthing that. Epithelium is the lining of the lung. It's all good. You guys, I told you to stop me if there was something that I was saying that was not reasonable. The lining of those alveolar sacs, okay, is called the epithelium. So it specifically directly affects the cells that are actually sitting around those alveoli and that are going to react to the inflammation. The other thing that we do, and I told you about this, is we work a lot with adult stem cells. And you guys hear all the time about stem cells and stem cells and stem cells. It can be made, stem cells can be made from any adult tissue. But the most common one is really the bone marrow, right? When you get a bone marrow transplant, you take bone marrow cells from that bone marrow. And these stem cells, the reason why they're so good is because they can become any kind of cell. You can make, for example, lung cells from a stem cell that comes from your bone marrow. You can make a heart cell from a cell that comes from your bone marrow. You can make skin cells. You can make eye cells. The important thing is that these cells have really important properties, and one of them is that they happen to be anti-inflammatory. They become all these different cells, and they also have this anti-inflammatory potential. So you've heard all about the stem cells, and you've heard that they can be used to make you, prettier. They can improve your quality of life. They can sort of be treatment for all kinds of tumors. They can be used in Huntington's disease, Alzheimer's. They're now being used in all kinds of fields. And of course, we're not far behind because sepsis is a really important field. So one of the things that we do in the lab is figure out if we can use these stem cells to treat sepsis. Our hypothesis is, of course, that the stem cells are going to make these endothelial and these epithelial cells, so the cells that line the vasculature and the cells that line the lung, that they're going to make them more powerful to deal with an infection. They're going to be antibacterial, and they're also going to be anti-inflammatory. So this is sort of a recent paper that shows that these stem cells, you can put them in either through the circulation, you can inject them into a patient, or you can instill them in the trachea through the ET tube. You just deposit the cells through the ET tube. And these cells have the ability to actually decrease inflammation. They change how angry the white blood cells are, and they also improve the lung function. Lots of papers have shown that these cells actually work. This is some of the literature. And the really important part for us is that within the challenge of this treating patients with sepsis and ARDS, there's a lot of meaning in being able to actually help these patients and improve their future outcomes. How do we translate this to patients? How does the research that I do in the lab, my poor students sitting there in the lab on a Saturday, 10 o'clock at night, you all are partying, my guys are working hard. How does this actually translate to patient care? So we are actually part of the Canadian Translational Biology Group. The Translational Biology Group under Laura Lynn McIntyre, who works in Ottawa. She's a critical care intensivist like myself. We're starting the first human trial on use of mesenchymal stem cells for patients with sepsis. We should be recruiting the first patient with any luck by March. And this could potentially be revolutionary for a disease where there's no treatment. There's no treatment for sepsis otherwise. All we can give patients is time. But this could potentially really change the landscape in terms of future management. The other thing that we do is here at St. Michael's Hospital, the Center for Critical Illness and Injury, we have a lot of investigators. We all work together to come up with clinical trials where you use all of the techniques that we learn in the lab, all the research discoveries that we do in the lab to actually translate into real practice. I added some videos about sepsis, sort of if you guys are interested and if you guys want to sort of inform yourselves a little bit more. A lot of them are from the Alliance Against Sepsis. 13th of September is the World Sepsis Day, so hopefully St. Mike's will be involved in trying to organize something for that. These are the people that I told you about that are working on a Saturday night. They're the people in my lab. They work very, very hard. And you should know that all videos are on internet, so I can give you all the videos. All the images are also on internet. They're a public domain. And if you guys have any questions, and I apologize for the videos, I really am very sorry because I didn't realize it was going to be such a nightmare to show George. You gotta win with a George Clooney video, right?
Okay. Thank you very much. Okay, anybody has any questions? Come on, please ask. It's not every day that we have such a great presenter with such an interesting topic. I think they understood everything. I have a question though. Oh, yeah.
You said one of the patients who has sepsis, their blood pressure goes down, but I want to understand why the blood pressure goes down.
All right. So there are many reasons, but the two most important reasons are that the bacterial toxins actually poison the cells, which in turn poison the mitochondria. If you guys have heard about mitochondria, right? The mitochondria make energy. And the lack of energy, the loss in ATP, these cells detach because they don't have any ATP. And they smooth muscle cells around the vessels that are supposed to contract the vessel when your blood pressure goes down. The normal response is for your vessels to contract, right? They don't work. So you have something called vasoplegia. Your vessels become paralyzed. They're stunned by the toxins made by the bacteria and the toxins made by the body. That's the first reason. The second reason is these toxins also affect the heart. In the heart, what happens is the left ventricle, which you guys know, pumps actively the blood. The left ventricle dilates. It becomes like floppy and big, and it doesn't contract actively. And failure is called circulatory collapse. Really, those are some of the main reasons. Those toxins cause all kinds of changes in your pH. So please pay attention in chemistry class and biochem, because pH is going to come and hound you in the future, okay? The pH goes down, patients become very acidic, okay? And the ability of receptors to actually bind to their ligands becomes significantly impaired. So at various levels, the body cannot react to its own immune response and to the immune response from the toxins. Does that make sense? Yeah, more or less? Yeah, sorry, go ahead. Oh, sorry.
If you were to add how come like if it's a bacterial infection that gets into the blood, how come like not adding like antibacterial into the blood?
You're smart. That's great. Thank you for asking that question. So I think most of us, sooner or later, ask ourselves exactly that question. How come getting rid of the bacteria with antibiotics doesn't actually cure the problem? Because I told you it's like an avalanche. This is like, you know, Pirates of the Caribbean, when you start going around that horrible funnel into like, because the inflammatory reaction of the body gets completely out of control. So getting rid of the inciting event, the event that actually triggered it, doesn't stop the body's loss of regulation. Part of it is also that as the sepsis becomes progressively worse, you also become immunosuppressed. because a huge inflammatory response causes a huge anti-inflammatory response. So these guys, their immune system, their neuroregulatory system is completely out of whack. And it is incredibly hard to wheel them in, like bring them in and stop this terrible vortex of demise. We don't have any medications to stop that. And interestingly, antibiotics, the time to antibiotics, how quickly you get the antibiotics there, is one of the major things that prevents the ultimate demise from sepsis or from acute lung injury for that matter. Because once the proverbial horse is out of the barn, you can't put them back in. You gotta get in there really quickly. How quickly? 6 hours. Golden hours of sepsis. Within the first 6 hours of evidence of circulating bacteria in your blood, right? And the inflammatory response, you need to be ready. You need to get in there really quickly and get rid of the bacteria before all of that dysregulation of the innate immune system happens. That makes sense? It's, yeah.
So, since you said that how the 6 hours were crucial, is that how the boy was able to survive?
The 9 month, the boy that that actually, I don't. Let me just rephrase. Not everybody that gets sepsis dies, right? So he actually had a really bad run because he lost a lot of digits. And remember when I told you guys that sepsis actually activates your coagulation cascade? So what happened to that boy probably is that he had microthrombi, small clots, in the small arteries, digital arteries, your toe arteries. These are very thin, they're very small. And once you get clots in there, those can block the circulation of blood into the distal sites, okay? More importantly, when we give patients medications to bring up their pressure, what do these medications do? What do you think, how could we bring up the pressure? They're vasoconstrictors. Good. Somebody whispered it over there. I don't know who it was. But so these are drugs that actually cause the arteries to spasm. And if you have a clot and then the artery spasms on top of that clot, it's like the pipes in your home. It's not nuclear science, right? If it blocked, you can't get blood beyond that spot. So he had all those digits amputated, probably because he had severe ischemia of those digits, right? Severe, no oxygen going to those digits. Now, when you get better from sepsis, if and when you get better from sepsis, that all reverses. Sometimes it's too late because those fingers are gone, but your heart, for example, goes back completely to normal. Patients, for example, that go on dialysis, that they don't have any urine output, their kidneys shut down and fail, if they get better from sepsis, their kidney starts working again. And really interestingly, why that happens, why sepsis causes such a profound shutdown, and then wakes up again like there's nothing, all right, I nearly killed you, and here I am, ready to function again. And the organs wake up and are ready to function again if you get this under control. So not everybody dies from sepsis. There's a lot of morbidity associated because so many bad things happen while you're down. But if you get back up, sometimes, not always, but most of the times, all your organs actually recover. It might not be permanent. So that guy, once it was over, he's left with the aftermath of the destruction of sepsis, but he's fine. It's a crazy disease. Very hard to deal with.
Yeah.
I think it's really cool to see how the stem cells are sort of improving the inflammatory reactions that are happening in the cells. And I was wondering if you noticed afterwards, sort of after this initial initial septic episode, do you see, if you sort of put in these stem cells, do you see any after effects of having other cells in the lungs? Like I was wondering if the diffusion of oxygen afterwards
Okay.
is harder to have extra cells.
So I don't know if I understand your question correctly. First, I think it's a great question, right? So if you were to have a transplant, right, you need immunosuppressant therapies, right? Because your body would react from an organ or a cell that is not yours. Does that make sense? Okay. Stem cells are called immunoprivileged. Why? Because they do not have, they're not mature enough to have the self-antigens on their walls. They don't have the address that says, I am from whatever. I am from St. Michael's Hospital. They don't have that. So they can go around the body without being detected as foreign. When you inject those cells, they have the ability to actually decrease the host's response to inflammation. They cause the patient themselves to develop an anti-inflammatory reaction, which is really great. It's not only that they're anti-inflammatory, but they can coordinate, they can orchestrate. They sort of say, okay, people, come on, let's go. You're all acting like silly people now. Let's stop with this inflammation business. Let's all single file down here. Let's get organized. You go there, you go there. That's what these stem cells do. They reorganize the immune system. And we have no idea how exactly they do that, okay? But they reorganize the immune system, so now, instead of acting like crazy, insane cells that are out there for the joy of inflammation and chaos, they start getting all reorganized and they start becoming anti-inflammatory and they start, acting properly, right? When you inject these cells, you don't need a lot. Because one of the risks, as you mentioned, is you put all these cells into somebody and you're going to cause a huge embolus. You're going to cause a huge clot of cells into somebody's lungs or into their vasculature. I mean, you're putting cells inside a person, right? And these cells, they don't do that because you don't need that much. With a little bit of cells, they have such powerful ability for coordination and orchestration and reorganization that you don't need too many. So they don't actually cause a lot, at least from lots of different studies that we've done, you don't need a lot of cells and they don't cause a lot of injury when you put them in. Do they make people better? We don't know yet. In sepsis and ARDS, I can tell you that a guy in San Francisco has used it for ARDS and we've clear evidence that they're safe. So because the first thing when you're trying to make a product for human consumption, okay, you got to make sure that you're not going to do anybody in when you give them the stem cells. So we know from lots of literature and from the study that now came out that these cells are very safe. They don't cause anybody any injury. Now the second question we have to ask is, are they effective? Do they actually do what you think they're going to do? Are they going to be anti-inflammatory? From the animal studies, we have tons of data that they are wonderful. They're the next best thing since sliced bread. They're like Velcro. They're fabulous. Having said that, we know many years, Jean, myself, and other critical care intensivists, that lots and lots and lots, how many? About 104, okay, if not more, clinical trials that have been sort of gone through the sepsis sort of pathway have ended up in the failed pile when they go to the clinic, when they go to actually for patient work. Why? Because patients are really complicated. And what works in the lab, in a little animal, little system that you're working, very often doesn't really work in clinic. So whether they're gonna be effective, yes or no, here is crossing my fingers. Because this could really revolutionize the way in which we provide care to critically ill patients. As I told you, these diseases affect anyone at any time. And in the ICU, with all those tubes and lines and IVs and ET tubes, those guys are sitting ducks, right, for terrible infections. So it may actually revolutionize the way in which we provide care. Now, do they actually improve oxygenation? it looks like, at least in the animal studies, it looks like they do. But you know what the real catcher is for ARDS? And I know you're not going to like this, and I hope that you guys are stimulated by the questions, right? If you improve oxygen in patients who have respiratory failure, that does not seem to actually translate into better outcomes. Isn't that weird? We have all this blah, blah, blah about oxygen, blah, blah, blah about oxygenation. I mean, no oxygen, clearly you die. But good oxygen doesn't necessarily mean that you're going to survive. Why is that? Maybe one of you will actually find that out. So hopefully one of you will go into research and we'll see you getting a Nobel Prize for discovering some of this really interesting work. So did I more or less answer your question?
Okay, so I think we passed around 5 minutes. So this is extremely important. Like Dr. Dos Santos said, the level of importance of this type of research is Nobel Prize level. We, despite all we do, despite treating the patient with pneumonia with antibiotics, like someone asked there, despite operating on a patient and removing like the George Clooney movie, removing the bile leak and whatever, the patient ends up dead if an overwhelming inflammatory response happens. And unfortunately now we can't control it. We give the patient time, and I really look forward to Claudia's clinical research to give us another tool to confront this problem. So thank you very much, Claudia. Thank you, everybody.
Thank you all. Thanks for coming.